Good afternoon, everyone, and welcome to today's webinar entitled Palliative Providers, Perfect Partners. We're glad that you could all join us as we have an insightful presentation in store for you today. My name is Deanna Fenton, and I am the Program Coordinator with the Alliance. Before we get started with today's presentation, we just have a few logistical items that we'd like to review. For those of you who have never joined us on this webinar platform before, please note that we will not be opening the phone lines. So if you'd like to submit a question, please do so using the chat feature located in the bottom left-hand corner of your screen. Please feel free to submit your questions at any time during the presentation. Once the presentation is complete, we will allow some time for our presenters to address as many of your questions as time allows. Registration is still open for our next webinar, Compassion Fatigue, Building Resiliency and Treating Burnout. That's coming your way on August 28th at 3 p.m. Eastern. Registration is also currently open for our next webinar, Brain Death Declaration, A Nursing Perspective, and that'll be coming your way on September 6th at 2 p.m. Eastern. You can register for all of these webinars and more on our website at organdonationalliance.org. For today's webinar, we are offering one SEPC credit and one nursing contact hour, courtesy of Iowa Donor Network. Everyone listening to today's webinar is entitled to claim continuing education credits. If you are listening in a group, as many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. As a reminder, for nursing you have 14 days to claim your credits, and for SEPC you have 30 calendar days. At this point in time, I'd like to introduce our moderator, Kim Totteman, Director of Transplant Center Relations at LifeLink of Georgia. Kim, we're glad to have you with us today, and at this point, I'd like to turn it over to you to introduce our speakers.
Thanks, Deanna. I'm really excited about our program today. I think palliative care is a journey that the opioid world has been on for years. Probably about 10 years ago, we first started talking about palliative care and how we might interact, and back then I think we all thought there's probably some crossover, some relationships, and we sort of struggled to figure out where it was. And I'm really excited to be at a point now where we're really starting to understand the value to each other in really working together and making sure that we're meeting families' needs at end of life. So I'm super excited to have two real experts in the field of palliative care with us today. And I'm going to go ahead and introduce them both because they're going to be presenting together and kind of sharing back and forth. So let me introduce them both to you, and then we'll go ahead and get started. First, we have Dr. Leslie Hunter Johnson. She received her Bachelor of Nursing from the University of Hawaii, a Master's of Nursing from the University of Phoenix, and a Doctor of Nursing Practice from the University of South Alabama. She has more than 25 years of experience in nursing in a variety of settings, including Queens Medical Center in Honolulu, Nathan Adelson Hospice in Las Vegas, as well as Sunrise Hospital and Medical Center in Las Vegas. As the Director of Hospice and Palliative Care at Sunrise, Dr. Hunter Johnson is responsible for coordination of service between the contracted hospice providers and the organization to ensure a transition to comfort. She works collaboratively with the Organ Donor Network to facilitate the donation after circulatory death process. And as a pain management nurse practitioner, she provides evidence-based care for pain and symptom management. Dr. Hunter Johnson is an advisory board member for the Nevada Organ Donor Network and a Patient-Centered Outcome Research Institute executive board member. She's also trained the trainer in End-of-Life Nursing Education Consortium in both critical care and core modules, education in palliative and end-of-life care, and for comfort communication. Dr. Paul DeSandre is the Chief of Palliative and Supportive Care at Grady Health Systems and is the Program Director for Fellowship in Hospice and Palliative Medicine at Emory University School of Medicine. He received a doctorate of Osteopathic Medicine from Kansas City University of Medicine and Bioscience in 1987. He's the former Associate Residency Director for Emergency Medicine for the Albert Einstein College of Medicine program in Emergency Medicine at Beth Israel Medical Center in New York and has a strong interest in medical education. His focus of interest is on the integration of emergency medicine and palliative medicine. He currently serves on the advisory board for the Improving Palliative Care in Emergency Medicine as part of the Center for the Advancement of Palliative Care. He also serves on the expert Advisory Council panel and is a master facilitator in the NCI-sponsored Education in Palliative and End-of-Life Care Emergency Medicine Project. Academic interests include educational interventions for the integration of palliative medicine into standard emergency medicine practice and residency training, as well as methods to incorporate effective palliative interventions in the emergency department for cancer, pain, and other symptom management. So as you can see, we have two highly qualified presenters to share with us today about our partnership. So I'm not going to tie up you guys anymore. I'm going to turn it over to Dr. DeSandre to get us started.
Thanks, Kim. So I'm very excited to be able to speak to everyone today about this subject with Leslie. I think this is something that has been evolving over time, and we're beginning to see more and more interest in the convergence of the two disciplines so that we can work together and achieve similar goals. I'd like to report no financial conflicts from either me or Dr. Leslie Hunter-Johnson. The objectives for today's session are three. The first is to define the role of palliative care in end of life, and to hopefully see how palliative care and organ donation have an integrated effort at end-of-life care. The second is to state at least two ways that palliative care can assist the OPO with the referral process. And third is to identify, again, at least one barrier to palliative care involvement in the ICU. There's many things that we share that are both goals as well as challenges. So what is palliative care? I think it's an important thing for the OPOs to be familiar with the language of how to communicate what palliative care is, not necessarily just to families, but also to teams that they might be working with. Because if they get involved in a case where there's a lot of conflict or there's a lot of concern about how the communications are going with the family, I think it is important for the OPO to advocate for palliative care involvement. So it's important to have some of the language at your disposal. I think if you can remember to communicate that it is specialized medical care for people living with serious illness, you're probably on the right track just to start, because that takes it away from a conversation about a misperception, perhaps, of palliative care being the service that's involved when a person's dying, which is a common misconception. Palliative care has worked very hard to be involved in trying to understand how we can best care for patients, regardless of where they are in their disease state. And as some of these other points make clear, it's appropriate for any age or any stage in a serious illness through cure or death and the bereavement of the patient. This is the involvement through the death and bereavement of the patient is a shared value for palliative care and for OPOs. Our goals in palliative care are to improve the quality of life for patient and family. So again, it is a collaborative idea where it sees the family and the patient as a unit of care. Our goals are also to relieve any symptoms and stress associated with the illness. In the case of organ donation, it might mean trying to advocate for proper approaches to the management of potential symptoms in a patient who might be going through a dying process. We also work as an interdisciplinary team, just as OPOs do, so that we can attend to all of the myriad of things that are faced by the patient and the family with a serious illness. Currently, there are over 2/3 of U.S. hospitals with palliative care specialty services. Now, that varies very significantly in terms of what the makeup of those different hospitals have for palliative care services, and we'll talk a little bit more about that. It's important to note that 90% of hospitals that have greater than 300 beds have some kind of palliative care service. So it is becoming a more ubiquitous presence in most hospitals in the U.S. We know that the demand for palliative care is increasing, and so palliative care practitioners are engaged in a lot of the care of patients in critical services. The goals of care and organ donation and trying to establish meaning at the end of life are a shared value that I think is easy to see with palliative care as well as with the OPO. When we're trying to talk through some of these things with patients and families, we're trying to understand how we can bring them back to some sense of meaning in what otherwise may feel like a completely meaningless situation or a very meaningless tragedy that may have occurred, and we're trying to bring them back to something that can generate a sense of meaning or even a sense of legacy for this family and the patient. One of the things that I think that this brings up is the idea that the opportunity for organ donation should really, I think, be viewed as a best practice at the end of life, meaning that if we consider the possibility for organ donation, we at least have the ability to include that in trying to understand what might bring meaning, what might bring value to this family through the eyes of their perception of the patient's best interest. That's typically the way the conversation is going. Now, some of the ways palliative care tends to get involved in the ICU I think is worth mentioning, because these are things that I think for an OPO you want to be familiar with in terms of has palliative care gotten involved? Should we be getting palliative care involved? So some of the common trigger themes that have emerged from one of the studies that was done through the Improving Palliative Care in the ICU project, this is from the Center to Advance Palliative Care, Judy Nelson sort of worked with a group of people, pulled together some of the common themes that are out there in the literature about ways that different teams construct triggers for when palliative care should get involved in an ICU. Certainly, family distress, symptom distress come to the top of the list, but poor prognosis for survival or an acceptable recovery is clearly an opportunity for discussion, and certainly intensive healthcare utilization. Now, if we're going to think of it purely from the perspective of an OPO, I think the first and the last are two really important ones to pay attention to, which is poor prognosis for survival or an acceptable recovery might trigger a conversation about, is this patient an appropriate potential organ donor, as well as in a family distress situation where if the outcomes are not going to be acceptable, or if it seems like the survival is poor, and the family is under distress, there's going to have to be quite a lot of effort to try to get to something of meaning that is concordant and can bring the family to peace over what is going to be best for the patient. Some of the things that are also shared between OPOs and palliative care are patient and family-centered decision-making. This is always one of the things that we try to drive home when we're training in palliative care, and I think OPOs work very hard at training the people that approach families about the possibility of organ donation on creating a family-centered decision-making process. The communication processes are myriad, and they involve not just the patients and families, but the teams, the staff, all of the consulting teams that might have a role in the possible organ donation process. So there's a lot of navigating that goes on in this process. That is true in palliative care as well. Emotional and practical support are a continuous element of both how palliative care maintains a therapeutic alliance with the patient or family. Same thing with the OPOs. Symptom management and comfort care are always going to be priorities. Now, palliative care focuses their attention on how to do this. The OPOs make sure that things are being done in the usual manner. Spiritual support is also something that's bilateral in its concern and provision, and organizational and emotional support for the ICU clinicians becomes a really important part of this. One of the things that happens when we're dealing with organ donation scenarios or end-of-life scenarios or withdrawal of life support is the effects that that has on the nurses and the staff in particular who've been caring for this patient, sometimes for a while. And so palliative care and OPOs end up getting involved in sort of the aftermath of these events. And so I think it's important to recognize that we inherently share some of the same intentions and our values. Some of the concerns that we have are also shared. And one of the things that I wanted to point out here is that we already have some information about what contributes to lower rates of organ donation refusal by families. It's related to the perception of not receiving adequate information, if they do not get adequate assurance of a high quality of care of the donor patient, if they don't feel like they're being understood, if death notification and the request for donation are linked rather than separated, if the setting is less than private, or if the requesters do not appear to be trained. So these are elements that make, I should have worded that higher rates, or I'm sorry, lower rates of refusal, yes, sorry. So I think it's, when you look at these concerns, these are also things that will impede the ability to come to concordant decision making for really any kind of medical intervention when we're talking about concerns that the family may have about doing or not doing a particular intervention. So these are the kinds of things that come up in palliative care all the time. In addition to some of the things that I think is important to note is that palliative care can also be involved, if they've been, in particular, if they've been involved with a case where the potential for brain death is happening, but it's not clear yet whether brain death will occur. Palliative care can be very helpful in the process of trying to help to maintain an alliance with the family and getting them through the dialogue about whether or not it makes sense to continue with brain death determination, in particular if the patient happens to be a high probability of organ donation if that's successful. Palliative care specialists are also going to be very focused on being skillful at the withdrawal of life support and the consideration for what happens to the patient, both from a symptomatic perspective as well as what the family's experience might be when you're taking somebody off any kind of physiologic life support. And so this is part of a donation process after circulatory death determination and an important part of where palliative care can maybe be a contributing partner. Leslie's going to talk about that in a little while. So some of the goals that emerge from efforts at trying to communicate to families in the ICU, I thought these were helpful to sort of keep on track. But again, I see these as shared goals in both opioids and with palliative care. Establishing trust, emotional support, assuring family understanding, as well as clinician understanding of the patient as a person, and deliberation of difficult decision making. All of these come up with the consideration of an organ donation idea. They also come up whenever we're going to be considering shifting the goals of care for a patient. One of the techniques that we use in palliative care, this comes from Vital Talk, which is an excellent program for communication skills. And we have several people here at Emory who've been trained in Vital Talk, and we work on training our fellows with this. One of the constructs that they use in Vital Talk is a mnemonic remap when we're trying to establish goals of care. I think this is worth mentioning because in remap we start by reframing the hope of the situation that they're experiencing with, as well as trying to reframe the circumstance that we're now dealing with. So if the family hasn't really come to terms with the medical understanding that the patient is going to die from their illness, that's something that has to be established before you can even talk through what are you going to do with this. How are you going to establish meaning? You can't even begin that process unless you're in a concordant place where you can say, we're in a different place now. And it looks like these things we've been trying to do aren't going to result in an acceptable outcome, or we expect that they're going to die from these things. That has to happen at the beginning. Certainly the process of responding to emotions is something that OPOs are trained in, as well as palliative care practitioners. But the one that really focuses the important connection between palliative care and the OPO is when we're trying to map the future. Because when we talk about what are we going to do with this situation, or what is going to make meaning out of this situation, there are many avenues we can cross. And one of them can be the removal of life support. If we don't consider whether the patient is an appropriate donor candidate, or whether it would have been an acceptable or highly desired idea for this patient, or from the perspective of the family, to be an organ donor, then we might inadvertently direct the family toward withdrawal of life support and miss the opportunity for organ donation as an option that could be something that might have provided meaning for the patient and family that would have been missed. That is a critical point in the conversation of goals of care, where if it is not guided carefully, can go in a direction that does not include organ donation, doesn't consider organ donation, doesn't even bring it up. So this becomes really important, so that if a palliative care provider is aware of whether or not a patient is an appropriate candidate for organ donation or a highly eligible candidate for organ donation, if they don't even know that going into this conversation, it can go very wrong, very unintentionally. If the palliative care provider is aware of this, then there can be a variety of ways that it can be either brought up or allowed for in future conversations. So in some places, the example might be maybe the palliative care providers don't ever bring up the idea of an organ donation possibility, but they allow for an OPO representative to talk to the family once they've maybe created tentative ideas of possibilities for the patient. Then they involve the OPO maybe by saying something like, additional end-of-life specialists will be talking to you soon. And then we'll reconvene once you've spoken with them. That may be one way of doing it. Another might be involving the palliative care specialist in some training with the OPO to be able to develop the ability to bring it up. Certainly if the family brings it up, that makes the whole process a lot easier, because then you can just offer them the opportunity to talk with the OPO and assure them that the OPO will help go through some of these ideas. The problem with this point in mapping the future, if we make a decision with the family that withdrawal of life support is what they think is best, the decision is now made. And the process of trying to prepare a patient for organ donation is a time-consuming process that doesn't have to be drawn out, but it is something to be aware of, and the palliative care providers need to at least understand what it might mean for organ donation to proceed. And it's not the same as we want them off the ventilator right away. We don't see any significance of it. Certainly, if regardless of everything you've talked about, that's all you've got and that makes the most sense to them, we are going to proceed with that approach. This is about creating options and making sure that they understand what those options actually are. So a couple of the other things to consider are once you've established some of the ideas that might make sense to the patient through the family's eyes, then you want to align with the patient's values. Aligning with the patient's values, if organ donation is going to be considered, might mean saying, what I'm hearing you say is it would be great if there was some way that we could make significance out of this. Maybe the idea of organ donation has come up. And then for the plan, it might mean I'm going to have you speak with the organ donation people. Usually we would give it by name. So in our institution, it would be, we'll have the people from LifeLink speak with you, and then we can talk about the details. So that's for the plan. So there's a variety of models for hospital-based palliative care, and these three are probably the most common that you might see or have experienced in your institution. The most common by far is the consultation model, and that can involve all of these people or some of these people or one of these people. So it's very different depending on the institution. The inpatient palliative care units are another way that this can occur. Usually there is established criteria for the patient to be accepted into an inpatient palliative care unit. Either the palliative care providers take primary care of the patient if the goals are already clear. If they're not, then it's usually a consultative approach where they have more intensive skills of the nurses and support staff in the inpatient palliative care unit for symptom control, et cetera. But the palliative care consultants are involved in each of those cases. The co-management model is also a model that's been around for quite a while and continues to be an important part of providing palliative care services. It's essentially developing the skills of the providers functioning in those environments, like in a regular med-surg environment, in the ICU, in the emergency department, so that they at least have the basics in order to function at a reasonably good level to manage palliative care needs for patients that come through their environment. At this point, I'm going to hand off to Leslie to talk a little bit more about some of the different hospital-based models and some of the experiences from her perspective.
Thank you, Dr. DeSandre, and welcome everybody. So I'm going to be reaching out to you guys now talking about different models. The first one is a teaching hospital, and it depends on the community and where you practice as what's going to be available. So teaching hospitals are usually associated with universities that may or may not have fellowships, and that is very helpful if you have a fellowship because there are people who are in the process of being trained specifically on how to have the critical conversation. But even in teaching hospitals, there's a wide variety of models. It can be consultative, primary, or collaborative. So, but the staffing, who staffs those models, is variable. In 2012 and 2013, all physicians who practice palliative medicine need to sit for a fellowship in order to be considered board certified in hospice and palliative medicine. Then you have to figure out how are they going to get their training, and that's primarily in a teaching hospital. So that's Dr. DeSandre does that in Emory. So that's a great service to provide a feed for the palliative care trained providers. APRNs, on the other hand, we have a variety of ways to get our education. It could be university trained, and there are several universities that have palliative care subspecialties. Hospice has their own variety, and that's the LNEC, which is End of Life Nursing Education Consortium, which is education on end of life, and there's various models within that program. And a lot of APRNs use that foundation to gain the extra training they need to be palliative care experts. But not all palliative care teams are involved in the DCD process. And that's what this whole focus is trying to engage those individuals who have palliative care with the organ donation network if you have not already done so, because it's a great network, because basically we speak the same language. We aren't, at this point, it's end-of-life care, but the palliative care experts have the extra knowledge and communication skills to help support the family. So what do you do in a community hospital that doesn't have a palliative care foundation, fellowship, or any type of education training? It's primarily going to be a consultant service because we need to have the trained individuals, and they're very rare to find. So if you have them in your community, you should really tap into their knowledge. But we also need to set a stage where we can get more of these into the providership. So in the community hospitals, we're primarily consultants because of the lack of the volume. So we're primarily a Monday through Friday service, at least in my hospital, and on call on the weekends. There is enough volume to provide 7 days a week, but unfortunately we don't have the resources for trained individuals to complete that 24-hour, 7 days a week service. But one model that does exist in many hospitals is the RN model. There are many RNs at the bedside who are experts in the communication, and they can assist the OPO in the discussion, supporting the family, So there's a lot of models out there that work just as an RN model and not PAs, APRNs, or physician model. So then we have the palliative care provider. So there are the individuals who are specially trained to provide this expert skill, knowledge, communication, symptom management. But then there's also an opportunity in many facilities to use the hospice medical director, because in order to be board certified in palliative medicine, the physician needs to have a primary board. So if they're internal medicine, they can sit for their palliative care boards after fellowship. But what does the hospice director do that their primary service is hospice? Well, a couple years ago, they developed the hospice medical director, which gives the certification to these individuals and now can help use their knowledge to help the community hospitals in providing this expert care. And a lot of programs are run primarily by APRNs, and that's what my program here in Las Vegas, in my hospital. I am the director of hospice and palliative medicine, and I work very collaboratively with our local OPO, both on early recognition of individuals who might be DCD, and all the way through the DCD process, including based on my scope of services, the withdrawal of care and the compassionate extubation orders. So in community hospitals, we have to think outside the box and use other services that can provide the same level of care. So what's important about the palliative care is we deal with the patient and the family as a unit. And this is very key when somebody is at the end of life, because the medical team and the medical providers are really good at managing the patient, but they often forget that the family needs support too. So the palliative care team engages the family. They're part of the whole conversation. How are you doing today? Are you getting enough support? So we deal with the patient and the family as a unit, and that's a little bit different focus than the primary care at the bedside that the intensivist or the hospitalist provide. So palliative care is symptom management experts, which includes pain, anxiety, secretion management, nausea, vomiting, all of those very distressing symptoms, because that actually affects the well-being of the patient and the family. The family's in distress when their loved one is in pain or appears to be in pain. So we try to manage those symptoms so the patient and the family can deal with their disease process. If you involve palliative care early, there's a lot of continuity of care. So I can see individuals from the emergency room through the ICU stay, through the med-surg stay, on to rehab, and we provide palliative care in all levels of service in our organization, which is very important. We are not primary, but we help concurrent management of the patient. So we try to make sure the patient has the symptom management early on, and we work that process through the hospitalization. And sometimes it moves towards the end-of-life care, and we manage the patient and the end-of-life as well. And APRNs in some states are allowed to pronounce death, and Nevada passed a law last year that APRNs can pronounce death in the DCD situation, and we're not unique. It's going on across the country. So that's a really interesting avenue to take, because it's new for most APRNs, and we need to use this foundation and use these experts and expanding the pool of the individuals who can pronounce at end-of-life care, because not everybody is comfortable with the withdrawal of care, since they call in palliative care, because that is our comfort zone. And even just the communication and the transparency that the palliative care team provides, that can be very beneficial through the donation process. So donation after circulatory death and DCD. In our organization, I'm involved right from the beginning of a potential DCD. Either the nursing unit or the OPO contacts me directly, because they want me to make sure that the individual is on my radar, that I am able to provide that expert level of care. I engage the family early, and what's important is palliative care doesn't just take care of the patient and it takes care of the family. Even after the death, I support the family. I'm at the bedside helping them through that. So the collaboration I have with our OPO is very beneficial. So I help with the co-management, some of the orders, some of the procedures, all of those things I'm able to coordinate on our end, and that's very unique because advanced practice nurses in Nevada are independent practice. So you need to use them to the fullest extent of their education and training. So when we're involved, we're communication experts, and it's like a four-way conversation. So we're discussing with the OPO, we're discussing with the family, and in some cases, we're actually consulting hospice, because what do you do with the individual who exceeds the allotted time for organ donation, and the organ donor network has decided they're no longer a candidate? Where does that leave the patient and the family? Well, in our world, we've already engaged the patient, we've already talked to the family, and we have, considered hospice as an option. So if the patient does exceed the allotted time, hospice is already there, already involved in the care, so we can then just move them into a hospice criteria. And then the hospital helps, because in our world, we don't have to actually leave the hospital to get hospice services. And I'm going to talk about that in the next slide or so. So when you involve the palliative care team, it can be a very superficial role or it can be very comprehensive. And I think in our world, my world, it's very comprehensive. Daily management of symptoms, everything that's in my scope of practice, I'm helping the OPO to optimize that patient's organs. But then in some places just have a superficial role because they've had the discussion and it's decided that they're going to go with the DCD, and the palliative care just steps aside and lets the OPO take over the care. But most palliative care see them from beginning to end through the process, and we build the trust with that family. But it comes with a price, the benefit and burden and involvement of the DCD process. So I'm often called even on weekends or on vacation, can you help me find a pronouncing physician? How do I do this? Who do I contact? So, it's a burden that I'm welcoming here in our organization because the outcomes have been extremely positive. So that's very helpful. But like I say, it's a benefit and a burden. I'm willing to take that burden, but it depends on how your structure is. If you don't have anybody on the weekends to help fill in, it makes it very difficult. But I have connections with the pronouncing providers, so I often help the OPO find a provider who's willing to pronounce in the death after the DCD process. It's very collaborative. So hospice, this is a philosophy, and Dr. DeSandre and I have very similar in what we do in the hospice realm. So hospice and palliative medicine is under one umbrella. Primarily, palliative care is appropriate at any age and any stage, where hospice is the limited life expectancy. So DCD is definitely under the realm of the hospice, but you can only have one covering entity at the time. So that means the OPO is moving forward with the DCD process in anticipation the patient will die in the allotted time. But as you know, there are a lot of DCDs that are family-driven, and we embrace that. And unless there's a clear reason for the OPO to back out, we usually move forward with the DCD. But we mean the palliative care is involved, and we're there. So if the patient does exceed the allotted time, I'm there to support them. They've never been, left behind. The family is aware, and very clear discussion and communication of where we go next. Because hospice will be involved, we can just basically roll them from an inpatient hospital patient to an inpatient hospice patient, and we never have to leave the hospital. So hospice should always be a forethought and not an afterthought. And if you don't have GIP services, general inpatient hospice services, or a collaboration with your local hospice, this is what I really encourage you to do, especially with the DCD process, because people surprise us all the time. We really anticipate this person is going to expire in the allotted time, but when they surprise us, and they do exceed the time, we need to have that extra layer of support. And hospice is more than willing to step up to the plate to fill that void, and they get continuation of services under the GIP hospice, not only for the patient, but for the next 13 months when the family is grieving. There's a place, an extra layer of support they can go to get those bereavement services. So if you're not engaged with a local hospice, I highly encourage you to do so. So medication management in the DCD, I do a lot of concurrent patient management, antibiotics, fluid challenges, making sure that the medication is, the patient's system is optimized by the medication management. But I'm also making sure that at the terminal extubation or compassionate extubation, as palliative care likes to share, because it's compassionately done, we treat all of our DCDs just like any other withdrawal of care, and we want to make sure that they are going to be expertly managed. We're going to manage the secretions, the pain, the anticipation of possible seizures. We're going to manage those medications compassionately. So especially at the DCD, when the family's at the bedside, they see that the patient is not suffering. They're very comfortable. And that's a peace of mind as the patient is passing, that the family gets to see that they didn't struggle, that they just passed peacefully. And that's very beneficial to the palliative care provider as well. We've done our job well in a sad situation that these individuals can now pass in peace and go on to save future lives. And then, very interestingly, heparin and TPA, as you know, for DCD, this requires a heparin dose or even TPA in several occasions to make sure the warm ischemic time and there's no complications. But how are you going to get the intensivist or the hospitalist to order 30,000 units of heparin or 300 units per kilogram? That's really outside their comfort zone. And even TPA, I mean, I've gotten challenge from the pharmacist when I've ordered TPA for the individuals going to procurement. And it's really out of everybody's comfort zone. But if the provider is comfortable with the doses and they understand the why, we're able to speak to that and order the appropriate dose to make sure there's optimization of that organ. So, but it's really out of most individuals' comfort zone. But when you work collaboratively with the DCD and the OPO, I understand the why, so therefore it makes the transition a lot easier. But there are a lot of barriers. Number one, do you have palliative care in your hospital? And a lot of people associate palliative care with end of life, though we do provide palliation at end of life. You don't have to be terminal to have palliative care, but in most cases we are. And then the awareness and collaboration. Do you have a trained individual? Are they in your building, or do you have to network with a local hospice or outside agency to get that palliative care services in? I work for the organization, so my response time is very quick, and so I can be deployed in the next 20 to 30 minutes as soon as I get the phone call, and that's very helpful. So when it comes to time, if I can deploy very quickly, I can engage the patient, engage the family when appropriate, and educate what's going on. I can evaluate the patient. Do I think this patient is going to survive the withdrawal of aggressive treatment? And that's one of the things that palliative care does when we're even considering inpatient hospice. Do we consider moving the patient outside of our organization to the local hospice? Or do we have the opportunity to transition them to GIP within our walls? And so we do a better evaluation, and we try, when possible, to identify people. I think they're going to survive, they're not going to survive, and I work collaboratively with the OPO, and we work together because we're a team. And maintenance of life support. So even though palliative care and hospice is very end of life and very pro-donation, we're also wanting to make sure the patients have the life support to maintain the organs as appropriate, whatever we need. Do we need the CBIGs, the catastrophic brain injury guidelines? Do we need to employ that? Do we need to do changes on the ventilator to make sure that they're optimal organ functions? So, that's important. So actions to consider prior to organ donation. Well, number one, offer hospice, because there's an extra entity who's willing to step up to the plate and help the patient and the family through the process of dying and through the process of healing. So again, it should be a forethought, not an afterthought. And then we have WOLST is withdrawal of life-sustaining treatment. So this should all be planned. We should make sure that the patient is pre-medicated before we withdraw the support, because as you know, in the absence of oxygen, there's a propensity for seizure. So we want to pre-medicate them. It's easier to prevent seizure rather than try to chase it and try to fix it. So we try to optimize the disease management and the symptom management before we withdraw, so then it is comfortable and seamless, and when the families watch their loved one take their last breath, it is peaceful. That's very, very rewarding to the palliative care team. So opportunities, I'm hoping that we can have successful collaboration models moving forward, because Dr. DeSandre and I really think that the collaboration between the palliative care team and the OPO is best practice. We understand what's going on. We all have the same goal, and we can work collaboratively. And hospice integration, if you don't have that, I would encourage you to network with your local hospice to get them on board, because they are a wealth of information and a wealth of knowledge, and you can use some of their expertise in your organization, especially if you don't have palliative within your walls. So then how do you get the training? So, many palliative care teams have been trained to begin the discussion of organ donation. If we're talking about to the patient and the family about end-of-life care, some palliative care teams have been trained to be the first approach. And if they're trained, that's great, because it's seamless, because we speak the language and there's no delay. But if not, we need to learn some palliative care skills. You need to make sure the patients are ready to hear their information. We need to be very transparent, because when patients are end of life, sometimes they feel like it's somebody's opinion. So when we can use as many evidence-based models, show them the CAT scan, show them the labs, be very clear in our communication, including the transparency, and that's part of palliative care, we can engage the families and minimize the conflict moving forward. And the OPO awareness, so I work very collaboratively with the OPO. So I know in our organization, consideration of somebody, I think they're going to go to brain death testing. I think we're going to be DCDs. So, what's really good too is on a palliative care model, you can't have a patient go to hospice and then to organ donation. It doesn't work that way based on the federal government and the guidelines. But oftentimes, when the palliative care is involved and there's consideration of brain death and it's not actually been confirmed, the bedside eval is consistent with brain death, but the patient may have had benzo or something on board where we have to wait the 48 hours. Sometimes we're able to move to DCD instead of conventional brain death testing if there is a cutoff or concern. And so we sometimes flip our switch from brain death testing to DCD testing, DCD procurement, because it gives a better pull. And sometimes, it depends on age and everything that's going on, we need to be aware of that. But the OPO and I work very, very closely. I sit on their board, I go to their meetings, and they contact me right away when there's even a consideration of a possible DCD. Okay, so then perfect partners. Why are we perfect partners? Well, we deal with end-of-life communication on a constant basis. And so it's seamless when we move from palliative care to end-of-life care, and we're able to expertly manage that withdrawal of life support. It's a collaboration approach, and it should be consideration of best practice for optimizing end-of-life care. We speak the same language, and in many cases, we can help the family, and even after the patient has passed, we engage the family even still, making sure they have had all of their information that they need to begin their healing. So palliative care is really best partner with the OPO, perfect partner for OPO. And there's a list of references. LNEC, they now have End-of-Life Nursing Education Consortium. They have an online module. It's not as touchy-feely as the real-life environment, but sometimes individuals who need the education can't get to those training sessions. That is very helpful, so you can get some of the education. Center to Advance Palliative Care, if your organization has palliative care, they probably have membership to to CAPC, and there's a lot of tools within that organization. So if you need a tool and you don't have a membership, ask your palliative care team, because they usually have, and there's a whole toolkit in there. Then there's the advisory board, consultative model. There's a lot of physician-driven education in end-of-life and palliative care, and they actually have an oncology version as well as the EPIC, and they have an online training program as well. So we need to improve our communication, we need to improve our collaboration, and we are truly perfect partners in palliative care.
Awesome. Thank you, Dr. Hunter-Johnson. So we have a couple questions coming up. Deanna, do you want to jump in and let everyone know if they want to pose questions, remind them how to do that?
Yes, thank you so much, Kim. So just as a reminder to everyone listening in, if you do have any questions that you'd like to pose to our presenters, please submit them using the chat feature that's located in the bottom left-hand corner of your screen. You can see an example of that here. And I'd also just like to note that during the Q&A session, I'm going to have this poll available. For those of you who are listening in a group, please complete this poll and let us know how many people are actually listening in your group. And with that, I'd like to turn it back to Kim to moderate your questions.
Thank you. So we have a couple questions up already. One of them is, who trains the palliative care physicians to approach families, and what are their consent rates? And I'm going to direct that to Dr. DeSandre. I think this is pretty new and pretty limited, but I know we are testing a model here at Grady.
Yeah, thanks, Kim. So, yeah, this is not usual practice. I should make that clear. There are different approaches that I think vary from institution to institution, state to state, in terms of who is allowed to talk about organ donation. In some states, it's very restricted. In Georgia, we have sort of an opportunity to have a collaborative approach, but the general idea is that providers who are not part of the OPO do not bring up organ donation. So what we talked about was, because of the obvious connection of palliative care providers having conversations about optimizing end-of-life care, the opportunity for withdrawal of life-sustaining therapies, which could lead to a withdrawal of life support in a patient who's a potential organ donor. We wanted to make sure that the palliative care providers had the skills and the comfort of at least being able to bring it up when it's appropriate. So we have a lot of communication with the OPO, and we had the OPO work with our palliative care team at Grady Hospital, which is a large public hospital with a relatively small palliative care team, and gave them some of the background skill sets, understanding about the organ donation process, so that they could initiate the conversation. This was not about going through the entire process of consent. This was only about bringing it up. And so then if it were met with a positive response that required further dialogue, then we would involve the OPO. Our general experiences of this is that the providers the palliative care providers feel that it has had pretty much no effect on the trust relationship, which was the biggest fear before we started this by the palliative care team. And from the OPO's perspective, it certainly hasn't impaired the ability to proceed with organ donation. I don't think we have enough data to say one way or the other whether it enhanced it, but I don't think it's in any way impairing it. If anything, it's keeping it on the table. So I think it is something to look at. and it's something for future study. I think it's going to be important to say if you integrate palliative care in the initiation of the conversation about organ donation, does that increase your success rate in proceeding to organ donation?
And that is a study, so hopefully we will have some publishable material sometime in the near future. We have another question that is about the transplant side of things. Do you have any experience or comments about the use of palliative care in the post-transplant period or proactively with transplant candidates prior to listing for transplant? And I'll direct that to Dr. DeSandre again coming from Emory.
Yeah, I appreciate that. The Emory University Hospital is a quaternary care center, so of course they are very involved in transplantation. So this involves both pre-transplant evaluations as well as post-transplant patients with complications. So palliative care does get involved in both of those scenarios. It varies in terms of the amount of palliative care involvement, and it really depends on the teams. Our feeling is that palliative care should probably be more of a protocol involved in any patient being considered for transplantation, because we feel like the concern is that if the patient does not progress to transplant, then they're still having to live with the uncertainty of that possibility at the beginning of the conversation. And if they do not proceed to transplant, they're going to have to live with the ramifications of living a life where they've been severely let down by something that they were hoping for. So my feeling and my team's feeling at Emory is that we should be involved in as many of those cases as possible. And certainly the complications of transplantation do result in end-of-life care. We are involved in many of those cases, including the withdrawal of life support such as an LVAD. So it is an important part of the work that we do at Emory.
Okay, I'm jumping to our next question. We have a lot of great questions up here, and this one will direct to Dr. Hunter Johnson. And it's, how would you suggest working with palliative care physicians who don't want to work with the OPO because they feel like participating in or recommending donation is a conflict of interest? And I think that's a very real concern that we've probably heard at every OPO from at least one program.
Right. So, palliative care is, focusing on end-of-life care. So and the palliative care physicians should realistically understand that there's end of life, and that's why that they are consulted. But not wanting to work with the OPO, we have to break down that barrier because it's really not a conflict. And number one, they should not be recommending donation because unless they're trained, like Dr. DeSandre said, it should not be part of their daily conversation. So in reality, the process of withdrawal of life-sustaining treatment is the same with or without the outcome of end of life and the organ procurement. But I'm the only person here. The person who supports me is a hospice physician, so he has no conflict. So it has to do probably with their education and training. And I'm not sure if Dr. DeSandre and your fellowship program, how do you deal with these barriers? Because I don't have the barrier, and I have a very limited pool and limited scope of what I do. So I don't have the other providers that have conflict. So can you share?
No, I appreciate that. And we have a fairly large group of palliative care physicians, nurse practitioners, et cetera, throughout multiple different locations at the Emory Palliative Care Center. So there are a variety of opinions. I would be disingenuous to tell you that all of my colleagues share enthusiastic support for organ donation, and I do think that it is a worry that they might be drifting away from being a pure advocate for the patient or family. My contention on this, which I think is a really important point, is that in order to provide optimal care in any situation, you actually have to provide adequate information. And adequate information includes possible options. And so caring for a person and their family toward the end of the person's life, if organ donation is an option, I feel that that's almost a necessary part of informed consent before you consider other options such as the withdrawal of life support, which all of my colleagues are comfortable discussing. So I feel that it's an aspect of informed decision-making. It's an aspect of shared decision-making. And I honestly believe that as palliative care providers, we have an obligation to include all appropriate information for patients and families to assure that we don't miss opportunities that they might have found meaning in. I think that that's an important thing to go back to. Is this coming from them or coming from the provider?
That's such a great comment. And I know we're about at the top of the hour, so it's probably a great way to end. If there's anything that you guys take away from today, I hope that it's that thought that when you're working with your palliative partners, giving them the thought that it really is part of good end-of-life care, that all opportunities and all information is shared as part of that decision-making process. There are a couple questions that we did not get to. One of them was about the collaboration in Georgia and what happens if the family responds negatively, and I will answer you that directly offline. There was also a question about if there are any OPOs that are considering hiring or funding palliative care, APRN, or fellowship at large hospitals. And so I would put out to the group, if anybody is doing that, would you please email me, and we can get that information out and shared with everybody. I'm not aware of anyone that is doing that. We are working with 2 palliative care fellowship programs in our state, and we are working with both of them to incorporate donation education as part of the fellowship, but not a funding thing specifically. So thank you all. Deanna, I'll turn it back to you to wrap it up.
Thank you, Kim. I'd just like to extend our sincere thanks to Dr. DeSandre and Dr. Hunter Johnson, as well as Kim, for your time and for an outstanding presentation today. I think everyone would agree with me in saying that it was very well received. And to all of our participants, I'd like to thank you for your time, and I wish you a wonderful rest of your week. Take care.